The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. This week, we are going to talk about the recently released program audit report for 2024 Medicare Advantage audits. We'll take 4 breaks today to divide this up, so let's get right to it. Many of you know that my expertise lies in government regulations, law, and policies. I particularly focused on Medicare Advantage compliance and regulation and helped start a company named MedHawk or MHK. While I have moved on, the core premise of the MHK platform was to ensure regulatory compliance throughout health plan operations, medical and pharmacy prior authorizations, appeals, grievances, complaints, and care management. I have particular expertise in special needs plans. The regulatory and compliance regime in MA has grown a great deal beginning in the early 2010s. 15 years on, the Centers for Medicare and Medicaid Services, or CMS, has developed far-reaching as well as granular protocols for MA plans to ensure fairness and equity in the delivery of benefits and services in the program. While sometimes I criticize CMS, overall I think it does a good job regulating MA, and I think it has developed a fair compliance and audit program. It does hold plans accountable. Notwithstanding what you hear from Democrats and increasingly Republicans, I think prior authorizations are largely done fairly by plans. After all, the goal is to reduce unnecessary costs in the system. Lawmakers and even CMS have politicized the issue a bit. Where I disagree with CMS is on a recent rule that requires MA plans to follow fee-for-service program coverage criteria. CMS developed and published what are known as program audit protocols and audit plans in 5 areas. The first, compliance program effectiveness. This looks at the oversight rigor the plan has over its delivery and that of delegated entities such as pharmacy benefit managers. The second is formulary administration. This looks at how a plan administers its Part D formulary and whether it ensures correct authorizations, claims payment, and cost sharing. Third, coverage determinations and appeals. This looks at how plans conduct prior authorizations, appeals, as well as Part D drug grievances. Fourth, the protocol is known as organization determinations and appeals. This looks at how plans conduct prior authorization, appeals, and Part C grievances for medical services. And fifth last is special needs plan care coordination. This looks at how plans ensure compliance with all SNP regulations and its filed model of care with NCQA. Not all plans have SNPs, but they are fast-growing. While other audit protocols are mature and do not change considerably, the SNP protocols are still evolving and maturing. I would note that the Medicare Medicaid plans, which are being phased out as of 1/1/26, have similar audits categories. As I noted, each year CMS issues its Part C and Part D program audit and enforcement report. I liked how CMS did it in years past, where actual plan audit scores, as well as average scores by audit area, were released. It gave you a great feel for where plans were struggling the most. Nonetheless, the report continues to be a good tool for Medicare Advantage and Part D plans to review and hone their compliance chops. With that, we will take our first break, and when we come back, we will take a look at the program audit report findings. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking about MA compliance and the recent release of the 2024 Program Audit Report. I now am going to outline the major findings from the most recent 2024 audit report, as well as the 2023 one. This gives us the best look at developing themes. So here's a little background first. CMS has been expanding the audits it does using both internal and external expertise. In 2023, a total of 69 MAPD contracts were audited. 31 of these contracts offered special needs plans. CMS also audited 14 standalone Part D PDP contracts, one 1876 cost plan, and 4 Medicare/Medicaid plan contracts. It was thus able to audit all 5 of the traditional program audit areas, as well as the 2 MMP areas. In 2024, CMS significantly expanded the footprint audited. CMS conducted 39 total program audits of 36 parent organizations in 2024. 19 of the audits were routine, that is, full scope program audits, and the remaining 20 were focused audits. That is, limited program areas were audited. The routine audits covered over 14.9 million Medicare beneficiaries. The routine audits covered 181 MAPD contracts, with 103 of these contracts offering SNPs, 10 PDP-only contracts, 1 1876 cost plan, and 12 MMP contracts. The focused audits covered an additional 290 MA or MAPD contracts and nearly 24.3 million Part C beneficiaries. In total, 2024 program audits covered 494 contracts, almost 88% of the total Medicare Part C population, and almost 69% of the total Medicare Part C and D population. So let's go into a findings overview here. Note that I am including findings from 2023 audits and 2024 audits, so you can document trends and emerging issues found. CMS outlines the 5 audit protocol areas. I am not covering that here, but it is in the report. But I do want to note that 2024 audits represented CMS's first thorough opportunity to assess compliance with some of the Part C utilization management requirements finalized for 2024. In 2023, it did do ad hoc audits on progress toward implementing the 24 rule. I have been very critical of applying traditional fee-for-service coverage criteria to a managed care program. As I say, it takes the managed care out of managed care. Some plans have seen cost increases, especially with inpatient and post-acute care. This will undoubtedly increase over time. So the focused audits really looked at the 2024 rule I just discussed. Specifically here, CMS assessed whether plans complied with national coverage determinations, local coverage determinations, and coverage and benefit conditions included in the traditional program, whether they used internal coverage criteria when the plan determined Medicare coverage criteria was not fully established, and whether they denied a service based on lack of medical necessity when it previously approved the service through prior authorization, whether it used a physician or other appropriate healthcare professional with expertise in the field of medicine or healthcare that is appropriate for the service at issue when it expects to issue an adverse medical necessity decision, whether the plan made internal coverage criteria publicly accessible, and finally, whether the plan established a utilization management committee to develop and review all utilization management policies and procedures. So with that brief overview, let's get into the meat of the 5 audit protocol findings in 23 and 24. So first, again, we'll look at the compliance program effectiveness findings. CMS has been paying a lot of attention here, especially in the area of delegated oversight. In the past, this has been a relatively easy area for plans to comply, but more recently, CMS has seen more issues here. It has been very concerned about a plan's oversight of delegated sales and marketing entities, such as third-party marketing organizations. Due to complaints, CMS has instituted new oversight requirements for plans, as well as sought to overhaul compensation, but the compensation rule was stayed in federal court. Thus, the compensation reform is on hold, and CMS will need to up its oversight of plans in this area via program audits. In this area in 2023, CMS found the following. Compliance issues were not tracked, addressed, or corrected. Compliance departments were not aware of internal auditing and monitoring results. Turnover within the organization interfered with planned oversight activities. In this area in 2024, CMS found that compliance issues continued not to be tracked, addressed, and corrected. Internal routine monitoring processes did not detect untimely notifications to enrollees when a delegated entity misinterpreted regulatory requirements. In 2023, CMS recommended that plans have clear procedures for timely communication of auditing and monitoring results to the compliance department. In 2024, CMS recommended that plans implement routine monitoring to oversee their delegated entities in order to ensure CMS regulations are being followed. I would add that too many plans fail to implement best practice oversight of all their delegated vendors. Using a best practice agenda with all delegated areas covered and monthly or quarterly meetings would go a long way to achieving better oversight and identifying non-compliant activities. If you don't ask your delegates if they are compliant in all areas, they will not tell you where the problems lie. With that, we will take our second break, and when we get back, we will cover additional audit protocol areas and findings by CMS. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking about MA compliance and the recent release of the 2024 Program Audit Report. We're going to continue on with our review of the findings in the audit protocol areas from the program audit reports in 2023 and 2024. Next on the list is formulary administration findings. Formulary administration has always been a trouble spot for plans. CMS has been focused on ensuring correct claim system configuration of the formulary and tiers, cost sharing, transition, and utilization management edits. In this area in 2023, CMS found claims were inappropriately rejected at the point of sale, enrollee eligibility files were not updated timely to reflect active coverage, prior authorization edits for new starts were not configured correctly to recognize enrollees with prior claims history of the medication. In this area in 2024, it appears CMS upped its review and found many technical violations. Plans inappropriately limited access to covered drugs on their formulary by applying unapproved edits, incorrectly effectuating authorizations, or improperly processing enrollment and eligibility. Beneficiaries were inappropriately restricted to a single strength or dosage form when plans effectuated the approved medication in their systems. It noted this restricts enrollee access to medications and increases provider burden by requiring the submission of a new coverage request for the same medication. Unintended quantity restrictions or inappropriate application of day supply limits on prepackaged medications below the plan benefit allowance also prevented enrollees from receiving the necessary prescribed quantity. As well, inadvertent termination of enrollees when updating eligibility files prevented enrollees from accessing necessary medications. In 24, CMS also found that plans did not provide temporary Part D transition supply allowances under required rules. Transition-eligible medications or transition supply notices were not provided due to improper coding logic. This restricts enrollee access to medications and prevents enrollees from understanding the steps needed to submit a coverage determination to obtain the medication or switch to an alternative. Enrollees with an established history of using a medication for Part D indications also were prevented from receiving a transition-eligible medication due to the application of inappropriate medically accepted indication edits. Finally, continuing enrollee claims history were not migrated in plan systems, preventing enrollees from receiving transition fills. In 2023, CMS recommended that plans tailor their monitoring of rejected claims to identify patterns that may be indicative of errors in their systems. This is a wise recommendation. Plans simply do not spend enough time looking at claim reports to find these patterns arising from improper claims configuration. In 2024, CMS says it does not want to get into the middle of claims configuration and effectuation logic, but notes that plans need to ensure coverage for medication strengths and dosage forms subject to the same formulary criteria. If a medication requires prior auth, and that prior auth requirement is the same for all doses of the medication, the plan should not limit the effectuation of the drug to a specific dosage. CMS recommends that plans consider whether effectuation of a drug should be done more broadly in situations where the formulary requirements do not change for different strengths or dosages. Next, we're going to move on to the audit protocol area, coverage determinations, appeals, and grievances findings. CMS has always been very active on the CDAG front. In my years of tracking, I would say this is perhaps the audit area that gets the greatest oversight. Auditors tend to go deep into cases, including timeliness, medical necessity criteria, appropriate decision-making, and clear and concise directions on denials. As a plan executive, I or one of my deputies would review such reports each day. In this area in 2023, CMS found coverage requests were misclassified and processed only as grievances. Staff did not recognize complaints about access to or cost of medications as coverage requests. Dismissal notice templates were not updated to include the reason for the dismissal, the right to request the plan vacate the dismissal, or the right to request redetermination of the dismissal. Note the reference above to vacating the dismissal. CMS's new regulations require plans to have a dual strategy to help members receive needed drugs quicker. In this area in 2024, CMS also found valid requests for coverage were dismissed due to a misinterpretation of CMS guidance. Coverage requests were misclassified or inappropriately dismissed, resulting in enrollee delays in accessing medications. Internal processes for correctly classifying coverage requests were insufficient and are not followed. Requests for coverage were inappropriately processed, causing enrollees to experience delays in receiving necessary medications. Electronic prior authorization configuration logic processed redetermination appeal requests as initial requests when EPA cases were submitted with different national provider identifiers. And last, clinical reviewers overlooked pertinent clinical information when considering coverage requests, resulting in inappropriate decisions. It is surprising that plans continue to struggle with appropriate recognition and classification of requests. This is easily addressed with training, job aids, which CMS has published, and auditing of workers' cases for process improvement and retraining. In 2023, CMS recommended that plans ensure that they are referencing the most current CMS guidance and regulatory requirements when processing coverage requests. In 2024, CMS recommended that plans ensure they put appropriate safeguards in place to ensure they recognize and process coverage requests, including coverage requests that come in through electronic systems and/or the call center. With that, we will take our third break, and when we get back, we will cover additional audit protocol areas. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back. We hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about MA compliance and the recent release of the 2024 Program Audit Report. We're going to continue on with our review of the findings in the audit protocol areas. Next, we will cover organization determinations, appeals, and grievances, as well as Medicare Medicaid plans, service authorization requests, appeals, and grievances. So these are the findings in these areas. I have found that while pharmacy turnaround times were faster and audit standards greater, plans always seem to struggle more with the ODAG area. Historically, audit scores in this area were worse than CDAG. Part of the issue could be the sheer volume of requests. Further, medical drugs now must be processed much more quickly, and timeframes now match Part D CDAG. In 2023, the same trend seems to hold. In this area in 2023, CMS found requests were not processed timely. Challenges with implementing new systems resulted in processing delays. Plans experienced increased workloads and staffing shortages. Established procedures were not fully understood and/or followed. Requests were inappropriately dismissed. Outreach for necessary clinical information was not conducted prior to dismissing requests. Misrouted requests were dismissed rather than sent to the appropriate department. Notifications were incorrect or incomplete. Dismissal notification templates did not contain the enrollee's right to request the plan vacate its dismissal. Non-contracted providers received remittance advices that did not include direct link to the waiver of liability form, and reasons for denial were not specific to requested services. In this area in 2024, CMS found decision notifications were incorrect or incomplete, which prevented enrollees and/or providers from appropriately advocating for services. Dismissal notification templates did not contain enrollees' right to request the plan vacate its dismissal. When cases were partially denied, notifications did not clearly specify what services, items, or drugs were approved or denied. Requests for coverage were inappropriately delayed. Internal processes used to review coverage requests were insufficient to ensure enrollees were notified of decisions timely. Reviewers overlooked pertinent clinical information when processing coverage requests that indicated services should be approved. Coverage denials were inadvertently issued due to a system logic error. In 2023, CMS recommended that plans oversight processes should focus on both content and timeliness of notifications, including specific criteria applied to reach medical necessity determinations. In 2024, CMS recommended that plans ensure an enrollee's medical history, for example, diagnoses, conditions, and functional status, physician recommendations, and clinical notes are considered prior to issuing an adverse medical necessity decision. So let's now get to the final program audit protocol area, known as Special Needs Plans Care Coordination and Medicare/Medicaid Plan Care Coordination. So what are the findings in this last category? CMS has been busy honing its regulatory approach for the SNP protocol, and requirements and oversight have become far more rigorous. We can expect the SNP protocols to become stricter over time as CMS seeks to further integrate Medicare and Medicaid, and as SNP growth explodes. SNP enrollment has now reached over 20% of all MA members. Because the SNP protocols are newer, audit results have been the most negative in recent years, the highest scores. CMS has always put a premium on timely execution of health risk assessments and care plans, as well as the ongoing update of such plans when a member's status or risk changes. CMS also wants to understand what SNP plans are doing to proactively improve outcomes and health when issues are identified. It is also important to remember that a plan is graded not only on the SNP regulations, but also on how a plan complies with its filed model of care with NCQA. So in the SNP protocol area, this is what CMS found in 2023. Individualized care plans were inconsistent with plans approved models of care or not updated timely. Individualized care plans were not comprehensive or did not account for changes in health risk assessments, the health status, or care transitions of enrollees. And communication around care coordination was ineffective across care settings during transitions. In this area in 24, CMS found that individualized care plans did not address all the results from enrollee health risk assessments or include measurable outcomes. Results from the HRAs were not carried over to the individualized care plan as a starting point for prioritizing care and goal development. Plans relied on a risk stratification system that categorized enrollees according to their health status, rather than using the individualized results of the health risk assessments to determine which conditions should be included in the care plan. This limits the conditions incorporated into the care plan and prevents enrollees from determining which conditions they want to pursue as part of their care plan. In 2023, CMS recommended that plans communication include all members of the interdisciplinary care team to help support effective care management. In 2024, CMS recommended that comprehensive individualized care plans include identifying goals and objectives, including measurable outcomes, considering all results from the HRAs while focused on conditions an enrollee chooses to pursue. With that, we will take our last break, and when we get back, we will cover the UM-focused audit results, financial audit results, and conclude. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about MA compliance and the recent release of the 2024 Program Audit Report. With the main protocol areas done, we will take a look at next focused audits on 2024 rule findings. Again, CMS appears to be going slow here and allowing plans time to acclimate to the new rule. CMS says that plans are working to implement the new requirements, generally adhered to coverage criteria in applicable national coverage determinations and local coverage determinations in the fee-for-service program, applied internal coverage criteria to ensure consistent decision-making for medically necessary services, conducted appropriate oversight of adverse decisions by appropriate physicians, and established utilization management committees in an effort to meet CMS requirements. I hear that CMS is slowly scrutinizing how plans have adhered to the new rule given the short time frame it was actually in force. No doubt the scrutiny will increase in future audit years, especially as it relates to application of the Two-Midnight policy for inpatient admission, as well as post-acute care reviews. So how about some other recommendations and findings? CMS included a section on suggestions for a successful audit. In 2023, CMS imposed 15 civil monetary penalties totaling about $450,000 for either program audit or financial audits. The areas fined included inappropriate cost sharing for Part C services and Part D medications, inappropriate denials and delays of Part D medications or Part C services, misclassification of Part D coverage requests, non-contract provider denial notice appeals rights, inappropriate dismissals, and inappropriate Part D premiums. In 2024, CMS imposed 14 civil monetary penalties totaling over $2.9 million for either program audits or financial audits. One fine to Centene for a financial audit was $2 million, but CMPs are still increasing dramatically from 23 to 24. The areas fined in 24 include inappropriate cost sharing for Part C services and Part D drugs, inappropriate denials or delays of Part D drugs, and misclassification of drug coverage requests. In terms of claims payment and appropriate processing of claims, CMS recommends the following coming out of financial audits. It is important for plans to ensure Part D claims are processed using the correct beneficiary enrollment and eligibility information. CMS notes that there are incorrect member loads or delays from the plan system of record to the pharmacy benefits manager. Inappropriately denied claims must be addressed after eligibility is corrected. The same is true for reprocessing cost sharing for low-income subsidy errors or updates. It is important that plans have effective oversight over their Part C claims processing system. They should conduct routine monitoring, perform system updates, and test system configurations to ensure claims are processed in accordance with each plan benefit design. So here are some final insights. As for the regular program audit areas, much of what occurred in 2024 matched 2023. Plans report that the level of scrutiny, though, is increasing dramatically over the past few years. Auditors have become extremely diligent in diving deep into each case end-to-end and examining the decision-making and criteria used. As well, a major focus and concern was the appropriateness of correspondence back to the member and provider to ensure any denial was clearly spelled out and what the next steps would be to obtain the service or drug. So let me conclude here by telling you about what I think are some of the most important findings and trends in the major program areas. Formulary administration, a focus on correct claims configuration and edits to ensure correct member cost sharing. I cannot emphasize enough CMS's focus here, as well as within financial audits. A long-running finding has been that MA plans do not configure and test their PBM claims correctly, leading to denial of formulary drugs, unapproved utilization management edits, and wrong cost sharing. In addition, the newest trend is CMS focusing in on eligibility updates to the PBM system. It is finding delays in updating information, which leads to incorrectly processed drug requests. There should be no lag, or no more than a very short lag of a few hours, between eligibility flow from CMS to the plan and the plan to the PBM. In the CDAG area, the continuing deep dive into all aspects of the pharmacy request, from timeliness to decision-making to appropriate communication. In addition, plans still struggle with correct classification of simple inquiries, coverage requests, appeals, and grievances. Remember that you may have to classify a request as both a grievance and as a coverage request or appeal. In addition, you must check whether a request has previously been processed, which would make a new one an appeal. Most important, clinicians must review all clinical information and apply each person's circumstances in case decision-making. In the ODAG area, similarly, there was an end-to-end focus on the case and attention to appropriate decision-making and communication. Some key focuses here include adequate outreach to providers for additional information, clear and concise denial language and appeals rights and correspondence, correct classification as with CDAG, and clinician review of pertinent clinical information. In the area of SNP, continued focus on assessments, care plans, and interventions. CMS continues to demand new ways to identify risks and intervene timely in care for every member in a SNP. CMS is moving beyond HRA's compliance to examining whether care plans address all known problems identified for the member. Comprehensiveness of the individualized care plan is key. On financial audits, as noted above, CMS is going deep into ensuring no beneficiary harm from the standpoint of what is charged to member and cost sharing. A constant auditing of the configuration of the PBM and medical claim systems is key, along with ongoing eligibility updates to each. With that, we'll conclude this edition of the Healthcare Labyrinth Podcast. We'll be back next week. See you then. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.